Good morning, everyone. My name is Alon Avidan. I'm here to give you a lecture and a summary of parasomnias. The other title for this lecture is Complex Nocturnal Behaviors. So I'm Alon Avidan. I direct the UCLA Sleep Disorder Center, where I serve as also professor of neurology in the Department of Neurology at the UCLA School of Medicine, at David Geffen School of Medicine. So a pleasure to have you on board. And we're going to go right through and go through some of my disclosures. Really, none of them pertain to this particular lecture. And let's go through some of the clinical presentations that one may encounter, as most of you are available to see patients and really encounter folks who come into the sleep clinic with complaints of insomnia or complaints of excessive daytime sleepiness. The abnormal nocturnal movements or abnormal nocturnal behaviors or some of the parasomnias, which I'll define shortly, are one of the most fascinating, I think, as a sleep physician. They're one of the most fascinating conditions that you will encounter because you almost have to play a detective role in trying to ascertain what a particular behavior is, what is the nature of the behavior, what its mechanism, and by understanding the mechanism, it's really a pathway to understand the underlying treatment for that particular condition. Let's define parasomnias. Parasomnias are undesirable motor, verbal, sensory phenomenon that arise from sleep or sleep-wake transition. And you can see in the gentleman below from Dr. Carlos Cheng from University of Minnesota. This is a patient who has this episode of a dream enactment. He's acting out his dreams. Dream enactment is part of the requirements to make a diagnosis of REM sleep behavior disorder, which is a REM parasomnia. The parasomnias and any complex nocturnal behaviors are really defined by the time during the night and the sleep stage in which they occur. So most of you know that individuals who present with a restless leg syndrome are folks who often present with evening time restlessness. They often experience the symptoms of an urge to move the legs, usually during the entire day, but in the evening time, it gets worse. What's interesting about some of the REM and non-REM parasomnias is that the condition is really manifesting, generally speaking, right at the first half of the night when we're talking about the non-REM parasomnias or disorders of arousal, and REM parasomnias, rapid eye movement sleep parasomnias, when REM sleep is more frequent in the last 1/3 of the night. This is a key issue because it will help us when you see those patients to really understand if the patient presents with episodes at 3 or 4 in the morning, it is more likely to be associated with a disorder during REM, rapid eye movement sleep. And that's really important also because nocturnal seizures generally occur by and large during episodes, during the sleep stage, which facilitates seizures during non-sleep. Hence, they're more common in, generally speaking, the first half of the night. Now, let's move on to some of the criteria or the definition of parasomnias based on the sleep stage that we've just outlined. So REM parasomnias generally are those that occur during REM sleep, and then the primary one here, the most critical one to understand and be aware of, is REM sleep behavior disorder or RBD. We also have episodes of sleep paralysis outside the narcolepsy spectrum, where the episodes do not exist in the setting of severe hypersomnolence. Isolated sleep paralysis is very common, and it's usually associated with sleep deprivation. We also have nightmares as part of the REM parasomnias, which of course have to be differentiated from sleep terrors. I'll go over that in a little bit. Then the disorders of arousals, we have confusional arousals, sleepwalking, somnambulism. Sleep-related eating disorder is a subtype of sleepwalking. And then again, we also have sleep terrors. Other parasomnias really exist as a condition or as a category where things, where these conditions are rather rare and do not really fit into REM or non-REM. And an example is sleep anuresis, sleep-related dissociative disorders. Sleep anuresis, by the way, is very common in pediatrics. I will not be discussing it today. And then you have isolated sleep or isolated symptoms, normal variants. Sleep talking is a key element here. All right, let's move on to the next slide. And here I'm going to show you how one divides and conceptualizes parasomnias. As I've mentioned, the first half of the night usually comprise of non-REM sleep, which is when you would see folks who experience disorders of arousal, the non-REM parasomnias. REM parasomnias in the last 1/3, where REM sleep is more dense. REM sleep behavior disorder, REM nightmares, isolated sleep paralysis are the prime examples. And then nocturnal seizures. And by the way, nocturnal seizures are usually manifesting as episodes when the EEG is highly synchronized. That's very common during non-REM sleep, slow wave sleep, stage 2. And this is when you would experience, in the first half of the night, you would experience nocturnal seizures. And remember, REM sleep, the EEG of patients during REM sleep is fairly desynchronized. It's highly irregular. It's almost protective against experiencing nocturnal seizures. Okay, and plus, remember, your muscle tone, your skeletal muscle tone is fairly atonic. You're paralyzed during REM sleep, hence it's another protective mechanism against having nocturnal seizures. All right, so in this particular gentleman, this is an interesting phenomenon. It's not really a parasomnia, although it looks like one. This is a sleep transition disorder, and it occurs right at sleep onset, and you notice that the patient is having some sort of a rhythmic phenomenon. And whenever people have a rhythmic stereotype phenomenon, we get concerned about seizures, but the timing here was a key to the diagnosis. It only arises as the patient is trying to fall asleep, and it's specifically seen in children, and it generally goes away after about age 9 or 10. This is a rhythmic movement disorder. In this form, the patient has a body rolling. There is also body rocking, head rocking, and head rolling. Those are the subtypes of rhythmic movement disorders. And you can see the EEG shows a very nice 1 to maybe about 3 hertz slow activity that is periodic, phasic, artifactual, spreading to the rest of the EEG electrodes, and really existing, particularly as a patient is trying to fall asleep during a drowsy sleep, and then it goes away, and the patient doesn't have another episode until the next awakening or the next night. All right, so this is not really a parasomnia. It's considered sleep-related rhythmic movement disorders, are really movement disorders of sleep where you have restless leg syndrome and periodic leg movements. This is not a parasomnia, but of course it can be confused with a parasomnia. So here's a patient who is having this peculiar episode of an awakening, an arousal. And as you can see, this particular gentleman looks a little bit unclear where he is. He's looking a little bit confused. This is happening during non-REM sleep. And of course, you would appreciate that he's not really having any displacement. This particular patient does not appear to be in terror. Hence, the most likely diagnosis here is confusional arousal. And I'll show you another example later on. But here, patients, very interestingly, they wake up during non-REM sleep, usually during stage 2 or 3. They have it lasts for about a minute or two. They appear confused, disoriented, and then it goes away. This is a disorder where sleep inertia is prolonged. And you can see the cartoon on the bottom. The patient looks a little bit almost drunk. The other condition or the other term that is used here is sleep drunkenness or sleep inertia are quite synonymous. And what they mean is the patient appears to be neither asleep nor awake, but they appear to be somewhat confused and disoriented. And this is really what defines the disorders of arousal. There is this momentary appearance of confusion, disorientation, and that period of a transition from sleep into wakefulness is prolonged. And during that period of time, it's really hard to tell what stage of sleep the patient is in. It's easy to tell right when the patient, just before the patient has their episode, but then it becomes increasingly more difficult. All right, REM Parasomnias in this particular example, I'm showing you dream enactment. The patient has dreamentation and is experiencing the episode during rapid eye movement sleep. Of course, you'll see characterizations of the EEG and brainwaves of a desynchronized pattern, mixed frequency EEG with maybe a little bit of sawtooth waves just before the episode, motor paralysis, of course, and rapid eye movement that would be found on the EOG electrodes. And you will, of course, find augmentation increase in motor activity, something I've not shown here yet. But again, here are the REM parasomnias, last 1/3 of the night, consisting of RBD, REM nightmares, and sleep paralysis. And here is the example. So here is a dog with a REM sleep behavior disorder, as well as a patient from Dr. Schenk's lab over at University of Minnesota. Both have a dream enactment, quite vigorous, quite dramatic, and by and large, most patients with this parasomnia will have some degree of a mental recollection. They'll wake up, they would appear somewhat alert, they would remember the episode, they'll tell you about dreams, and if they don't, that's okay still, but they will not appear confused, which is something that is very common among folks with non-REM parasomnias, for which there is complete amnesia, typically complete amnesia to the episodes. Some patients would and may have some recollection of unusual hallucinations, but that's not very common. The underlying pathology or pathophysiology of parasomnias is related to the incomplete transition between sleep and wakefulness. I just want to show you one other example. In this particular dog, and most of you can probably find this video on YouTube. It's a fascinating video. You can see the patient is, this particular animal has vigorous running movement, running, dreamentation, running after a rabbit probably, and then, oh my gosh, this looks quite dramatic, and you can appreciate that the risk for injury is quite significant. So why don't we, now that we understand these are really fascinating conditions, we need to know about them because of the risk for injury, why don't we talk a little bit about the underlying pathophysiology, maybe something less exciting, but nonetheless we really need. If patients ask you, why do I have a parasomnia, you can explain to them that this is really a condition where the transition between wake to sleep and wakefulness, from one REM stage into non-REM, all of this is a blur. And this, I'm going to show you the slide again. This is a complete overlap between various stages of sleep, and this overlap leads to this overlapping state of being leads to the expression of behaviors that are often automatic. They can be aggressive, they can be described as a patient appearing confused, and they have elements of both REM sleep and wakefulness, or non-REM sleep and wakefulness, but the patient is really stuck during this transitional period, and they appear to exhibit elements both of wakefulness, REM sleep, or wakefulness and non-REM sleep, and the behaviors are often what is really striking. And I'll go show you some examples. Of course, in the differential diagnosis of this parasomnias, one has to be very careful about really differentiating folks who experience episodes where the events are related to sleep, related somnambulism, sleepwalking here. This is a transition between non-REM sleep to wakefulness, overlapping between wake and REM sleep. This is where you will see the REM parasomnias. And also remember, cataplexy. Cataplexy is a condition where the intrusion of REM sleep occurs during wakefulness. So almost the same conundrum, the same spectrum of the parasomnias, but here we have almost the opposite expression of REM intrusion into wakefulness that's inappropriate. In RBD, you have inappropriate expression of wakefulness, elements of wakefulness in REM sleep. That is, the patient is losing their skeletal muscle tone and is acting out their dreams. And of course, one has to bring into the picture seizures and psychogenic spells. All right, let's start with probably the most important parasomnia. All of you probably know REM sleep behavior disorder, and you know about this because this is a condition that is particularly unique in older individuals, although now we're seeing it also in younger folks, but it's common with alpha-synucleinopathies. The alpha-synucleinopathies consist of alpha-synuclein in the cell body of the brain in these individuals, and it really highlights the underlying pathology that is related to the underlying condition, the underlying dementia. And it's very common in Parkinson's disease, dementia with Lewy body, and multiple system atrophy. Both are three key REM parasomnias with very strong predilection for patients to experience RBD even before the neurodegenerative condition takes place. And this is what's fascinating about it, because RBD, REM sleep behavior disorder, is a marker of neurodegeneration. And that's where you really need to know how this is diagnosed and know something about RBD because of its risk for neurodegeneration. You want to be able to diagnose it, certainly, so you can adequately advise patients about what to expect and have that discussion. Here's the classic paper from University of Minnesota, Carl Schenk, and of course, the last author, the late Mark Mahauld. The patients here who were first described in this seminal paper from Sleep, 1986, mostly men, older men who had injurious aggressive behaviors. The later observation really was that this particular group of patients went on to develop dementia. I do want to say, remind everyone that Dr. Carlos Schenk, who is here on this on the right side, here's Dr. Mahauld. Both are the key authors for this initial paper, and really are credited with the discovery and definition and characterization of RBD. And I want to mention that unfortunately, Dr. Mahauld passed away recently, and I want to really dedicate the slide in his memory for being one of the pioneers in really defining, characterizing RBD in particular, and parasomnias as a whole. Early on, even before the description of human REM sleep behavior disorder, we were aware, and this is due to work in Lyon, France, by Jouvet, who described a model in the cats where perilocus ceruleus lesions led to paradoxical sleep without atonia. This is really interesting because RBD was almost predicted earlier, at least 2 decades earlier, in animals who experienced this lesion in the perilocus ceruleus, which led to an anuric dream enactment behavior, paradoxical sleep without atonia. And remember, here are the generators of REM sleep, Russell-Pons. This always comes up on the board, so please remember it. Russell-Pons, this is where REM sleep is generated, and where you can cause lesions to produce secondary REM sleep behavior disorder or paradoxical sleep without atonia in laboratory animals. All right, let's move on. The associated demographics in RBD, as I mentioned, mainly older adults, older men. It's not really known why there is such a high male to female ratio. We don't really understand that. It may be that the dreams are more aggressive in men, or that men often manifest behaviors that tend to be more likely to be diagnosable because they often complain that they're the bed partners are often complaining that they're more injurious, or perhaps an expression of the development of the REM generating centers that might be sex steroid dependent. It's not really known. But before age 50, the male to female predilection is about the same. And remember, RBD before in a younger person below age 50, usually related to antidepressants, usually related to perhaps other direct neuronal injury, either related to vascular, demyelinating multiple sclerosis, as opposed to occurring in a setting of alpha-synucleinopathies. All right, let's talk about some additional findings. The additional finding is that RBD can be predictive of neurodegeneration later in life, and this has really gained traction over the last 10 years in particular, because now there are a lot of clinical trials that are looking at what further data really defines those patients. So when you see them in clinic, there are other conditions that may further define patients who may have a faster rates of phenoconversion. Phenoconversion is the transformation from one condition, one phenotype into another, from non-dementia into the dementia phenotype. And that phenoconversion can be accelerated if you also find that the patient has anosmia, lots of sense of smell, constipation, depression, orthostatic hypotension. And those are conditions that may predict and define the pre-Parkinsonism more discreetly. The associated features, as I've mentioned, aggressive dream enactment, potentially injurious behaviors. The episode starts with a sudden arousal out of REM sleep, expression of the dream enactment behavior, lasting about 30 seconds to no more than a minute or two, occasionally up to 3 minutes, very rare. But the potential for injury is what we are often worried about. In this particular patient with a RBD, you can see she suffered a basilar skull fracture. This is again from Dr. Schenk's laboratory. And by and large, most patients return to baseline fairly quickly, and they have no further difficulties with confusion or difficulties with transition right back into wakefulness, and they may or may not have a recollection, and if they do, it's very helpful. It tells us that the patient is likely in REM sleep, and it also tells us about how disruptive the episodes are, and the nature of the dreams often can tell us about the sort of behaviors that are most disruptive to the patient. And I'll go into this in a little bit more detail.
His arms punch and hit, and he also runs with his legs under the covers real fast.
Her husband's RBD,
and he clears the bedside table, the lamps, the alarm clock. That all goes off, and 3 times he's thrown himself out of bed and is sound asleep and doesn't wake up till he hits the floor.
I see.
One of those incidents is where when he threw himself in the fight, the bedside table went into the side of his neck, the corner of it, and he bruised his ear and the side of his face.
What I'm going to do, I'm going to turn down the volume. And by the way, I'm going to ask people, if you see that sign here for no photos, I respectfully ask that you do not take a picture of the video due to HIPAA compliance. But you can appreciate that really the patient is not the one who is most likely to be bothered by the condition. The patient here is on the left side. The bed partner is the one who is most bothered by the episodes. I'm going to put the volume way down again and repeat it. But take a look how animated she is in describing her husband's sleep disorder. He is actually not the one with insomnia. He doesn't have hypersomnia. He's not really scared going to sleep. She is the one who is always fearful of what's going to happen next. When is she going to get the next punch as he's having his dream enactments? So paradoxically, patients with RBD usually are not particularly symptomatic. It's the bed partners who are usually coming to medical attention because their sleep is disrupted, they have insomnia, and they have consequences the next day as they often get awoken and experience sleep disruption. Now, the type of dream enactment that people experience, and this is where it becomes interesting, and I ask you to always have your sleep technicians go back and ask the patient after they had their dream enactment, what was the nature of the dream, were they being chased, were there animals? Because by and large, about more than 2/3 of patients have to protect themselves during those episodes. They're usually having to defend themselves against other people or animals, usually reptiles or insects. It's very rare, not that rare, but it's uncommon. It's uncommon that patients are really the aggressors or that they're having fun sports-like dreams. This particular patient was dreaming that he was on a golf course and was hitting a golf ball, and during that episode injured himself. So aggression and defense of the patient against those who are trying to get them is what's common. And I remember I mentioned that this is common in a-Synucleinopathies, less common in amyloid type pathology or tauopathies. And in fact, if you have a patient who presents with RBD and the patient comes to you with a clinical history of presumed Alzheimer's type dementia, that you use this information to maybe reassign or redefine that dementia diagnosis and maybe examine the patient and look at other findings that may shift them to a different dementia category. There are 4 things I want you to remember about RBD. Really, it's really critical. The first C, the 4 C's include the first C, which is to conduct a consultation. You want to have a discussion with the patient, and I always make this point with our sleep fellows. If the bed partner is not there, call them up or ask them to come in for the next visit, because you want to get the history as accurate as possible. The patient doesn't remember what they're dreaming about or what they're experiencing, and that's true for all parasomnias. You want to have an eyewitness and conduct a consultation and see if there are any other factors that might be triggering the episodes. In RBD, you want to find out the timing, duration, get some examples. Ask them to give you a range of behaviors, give you a frequency. Knowing the frequency, severity, impact is going to tell you, do you really want to intervene with a specific therapy? The second C is corroboration with a polysomnogram. This is the only parasomnia for which you need a diagnostic confirmation by nocturnal polysomnogram. I'm going to repeat it. RBD, REM sleep behavior disorder, is the only parasomnia by definition where you need to corroborate, you need to have a diagnostic polysomnogram with expanded EMG montage to confirm the diagnosis. Treatment is primarily using melatonin or clonazepam. Clonazepam is a 3rd C. And finally, you have to have a conversation. I think that's probably the most important part, is after you make a diagnosis and you treat the patient medically, you have still not managed them. The management really is being holistic. You want to be holistic about what does the diagnosis mean. And in this particular parasomnia, it means that the patient could have onset of neurodegeneration, and you must have a conversation. I will say that this is a very physician dependent. Some physicians feel comfortable talking about the potential for phenoconversions, others do not. And it's all up to you, but by and large, if you tell patients about that they have RBD, they're going to be going to the internet and reading about it, and they're going to find out that there is a likelihood of neurodegeneration, and then they're going to come back to you if you haven't told them and ask you, why haven't you disclosed that? So I think I will leave this up to you, but all of you see that there is probably good value in having this discussion or conversation. So the ICSD-3 diagnostic criteria is to demonstrate that the patient has abnormal polysomnography, elevation of EMG tone during REM sleep, and a history or observation during the polysomnogram that REM sleep, there is evidence of dream enactment. And you have to rule out, of course, nocturnal seizures and other conditions that might explain it. And here it is. Here is a polysomnogram with, you can see, expanded EMG with a, actually this particular example doesn't show the expanded EMG, but you can appreciate the elevation in REM tone, the EMG tone in the chin and the limbs. Now you can have one or the other. You don't have to have both chin and limb elevated. It could be only chin, or it could be only the limbs. And here is a patient with RBD. On the left side, left panel, you can see the polysomnogram. This is the first requirement, demonstration of RSWA, RASWA, REM sleep without atonia, has to occupy more than 50% of 30-second epoch by ICSD criteria. And AASM criteria. ICSD is a little bit different. It requires more than 27% elevation. But here's dream enactment. Dream enactment behavior with REM sleep without atonia gives you RBD. And here's how you score RBD. Here's how you score REM sleep without atonia, really, as a criteria for RBD. But you must take a look. Here's a 30-second epoch. Use intervals of a 3-second mini epochs by dividing the page into 10 3-second mini epochs, and if 50% of the 10 mini epochs demonstrate elevation of EMG tone, you have met criteria. Okay, so here definitely you can see from, you don't have to look even at the actual amplitude. You can appreciate that the EMG tone is quite elevated and quite abnormal in the setting of RBD. Now, one of the other reasons to do a polysomnogram is, of course, to rule out other conditions that can mimic RBD, like pseudo RBDs, untreated sleep apnea, causing and leading to dream enactment. Here is an example. Here is an apnea. The patient wakes up abruptly and has kicking of the legs and arms in a quasi-dream enactment manner. But we also have to rule out nocturnal seizures, non-REM parasomnias. Periodic leg movements can sometimes present as mimics of RBD. So a sleep study is fundamentally key in making that distinction. All right, so if you only have, let's talk about nomenclature. If you only have REM without atonia on the polysomnogram, you don't have dream enactment, the only thing you can say is the patient has REM sleep without atonia. You can't say that this is RBD, not yet. Or if you only have observation of dream enactment, you can't say the patient has RBD. You really need both the polysomnogram, REM without atonia with dream enactment to give you REM sleep behavior disorder. Okay, the same token, if you only have the PSG, the polysomnogram with elevation of tone, the other term for this is subclinical RBD. Okay, subclinical RBD is the finding of a REM sleep without atonia without known clinical history. Clinical probable RBD are recurrent episodes of dream enactment where access to a polysomnogram is limited and you haven't yet established the diagnosis by PSG. Idiopathic or cryptogenic. Most of you are aware of idiopathic RBD is RBD before the onset of neurodegeneration. It's more appropriate to say cryptogenic. Cryptogenic means something bad may happen later on, and this is a defining folks who may have RBD without any associated neurodegenerative condition, where secondary symptomatic RBD is RBD in the setting of Parkinson's disease or other neurologic comorbidity. Okay, so that's very important to appreciate and know of this classic nomenclature. You can also appreciate there's a chronic, acute, subacute, toxic, idiopathic is on the left, secondary is on the right. And you can appreciate that many of those individuals who have the toxic or pharmacologically induced are related to antidepressants, but also caffeine and alcohol withdrawal. Another cause of the secondary causes related to neurologic injuries I've mentioned, demyelination, paraneoplastic disease, a brainstem lesion from stroke, and everything else in the chronic form, in the idiopathic, is the transformation to a-Synucleinopathies or non-synuclein neurodegeneration ALS, Alzheimer's, spinocerebellar ataxia. So this should give you a rough classification of further phenotypes. Secondary in this form are usually folks who are younger, where the age predilection is fairly consistent. Male and female predilection is fairly similar. Idiopathic, usually over age 60, male to female ratio is about 9:1. We use to define RBD is Dr. Jekyll Mr. Hyde syndrome, simply to highlight the great paradox, or the phenomenon where the patient is very nice, very pleasant during the day, and becomes quite an aggressive, beast-natured individual during the night. And this is really what defines this paradox, what defines folks who really are having such a dichotomy in their how they're perceived by the observer, by the family, and bed partners. And this is why we have to treat RBDs. The likelihood for injury, I want you to be aware, if a patient comes to see you, you have to make a judgment call of when it is appropriate to start a patient on preventative therapy and medications. I think that all of you, when you're seeing these patients, you want to protect themselves, and before they see you, they will probably go through some of these treatments themselves. But safety is number one. That's level A recommendation. Modifying the sleep environment, being like a detective, removing any sharp firearms, machete knives, making the bedroom safe. So if the patient has their dream enactment and they kick the dresser, that they're not going to get injured. And barricading furniture is really critical. And I think that this makes sense, right? And you will probably do this for all parasomnias, really. It's to modify the bedroom environment, provide safety. That's level A recommendation. And you can see some evidence from the literature of individuals who already went through those specific recommendations. Then let's talk about pharmacotherapy. You all know that clonazepam is probably cited as probably the most commonly used treatment, but now we're seeing a lot of folks benefiting from melatonin, high-dose melatonin in particular. I want you to draw your attention to the article from the Journal of Clinical Sleep Medicine, 2010. This is currently being revised. And those level B recommendations, clonazepam, melatonin. If you use melatonin, we find that going to a higher dose is probably more helpful. Titrating that to clinical efficacy. We use in our clinic melatonin TR, or time release. It has a little bit more coverage in terms of being available later on at night. And here's an alarm type mechanism. This is from the Minnesota group, Mike Howell group, and the patient essentially has this alarm that pre-records a patient's wife or a bed partner. In this particular example, it's a wife, where the patients, when they hear their wives or bed partners mentioning something about going back to bed, something relaxing, to let them know they're having a dream, the patient actually goes back to bed, and they have a fairly good response. So here's an example. The patient is having a dream enactment, having a dream enactment, and in the background,
you're having a dream, go back to sleep.
The patient goes back to bed. The episode is over. So I think those of you who like to integrate innovation would find this particular example quite useful. Remember that secondary RBD is often related to many of the antidepressants, in particular venlafaxine, SSRIs and SRIs are critical. Here's venlafaxine-induced RBD. And the role of antidepressants has been well demonstrated in the literature. And it can be, it may still be that this patient, say, will go on to develop the neurodegeneration. So you can tell those patients who are on antidepressants that it's related to antidepressants. They do not have to worry about anything else. It may be that the antidepressants bring those patients to clinical attention earlier, and they still retain and have the same associated risk for neurodegeneration later in life, but probably at a young, with a diagnosis made earlier. Now, having this conversation, what does this mean? You know, RBD is the tip of the iceberg, and with time, passage of time, neurodegeneration is likely to occur. And you can see almost a dose response from years of diagnosis of RBD. This is patients remaining disease free, and you can see that it's about a third in 5 years, 2/3 in 10 years will phenoconvert, and this is from the Barcelona group, about 90% in about 14 years. So here it is again, you have fairly, a fairly interesting range, all the way from 50 to 90%. And this may depend on the phenotype of the population being examined, but really having a history of RBD is really a window of opportunity to maybe start looking into drug trials where RBD is a marker of neurodegeneration, and one can introduce a medication or a compound to slow down or even prevent the neurodegeneration. This is what it's all about. And this is why it's so critical for you to be making this diagnosis correctly, accurately, and advising patients appropriately. All right. Let's move on to the disorders of arousal in the next 10 or 15 minutes. And really, the underlying behavior here can range from confusion to walking to eating to sexual behaviors to terror, really very wide spectrum, where distressed individuals are usually at the very one extreme, a semiology of prominent autonomic activity, heightened sympathetic activity, non-agitated motor activity, sleepwalking, and arousal with no motor or automatic activity is what defines a confusional arousals. And you can appreciate folks who present with sleep terrors are usually intense. They're distressed right at the very beginning. And then they sort of the motor component is decreased at the end of the episode. Somnambulism usually is the entire range of the behavior is manifested by walking, and this motor phenomenon. You can have hybrid episodes, a combination of two non-REM parasomnias, and parasomnia overlap is a REM and a non-REM parasomnia in a single individual. The underlying pathophysiology is related to the central pattern generators at the level of the spinal cord, the brainstem, which lead to this abnormal behaviors independently of cerebral control, with a range of behaviors ranging from locomotion to eating, speech, pedaling movements, with emerging behaviors that look defensive in nature or emotional, locomotive, and that can also serve, depending on the behavior, defensive, predatory, and elementary related to epilepsy, defensive, emotional, locomotive, more related to parasomnias. Now, parasomnias, in particular non-REM parasomnias, are not related to psychiatric conditions. They do have a genetic familial pattern. They're autosomal dominant. That's actually one of the priming factors. They are primed and they're actually exacerbated by sleep deprivation, psychosocial stress. And I can tell you with COVID-19, we've seen, I'm sure all of you have seen a lot more sleep patients who experience delayed sleep phase, circadian disorder, chronic insomnia, but also very vivid dreams and nightmares. So this will probably go on for some time, unfortunately. And you do have to have underlying genetic factors as a priming predisposing factors that are then triggered by untreated sleep apnea or stress or sleep deprivation, and of course in a lot of folks by medications that often drive the episode. Let's talk about confusional arousal. There is a sudden arousal, confusion, disorientation, amnesia, very rapid return to baseline. Sexsomnias is abnormal sexual behavior right following the amnestic type episode, and the patient does appear to be fairly well confined to the bedroom, and in bed. If there is displacement, you then redefine the condition as sleepwalking. And here's an example: partial awakening, disorientation, paraplegic, and amnesia to the episode. This is a sleep-deprived individual.
I'm gonna get electrocuted.
Speech, confusion.
I wonder if I might get hurt with this, or can I?
I'd say,
I don't think I can.
hard to say what stage of sleep she's in, but she's definitely non-REM. Take a look at what happens next.
Are you okay?
Oh, yeah.
Is back to baseline.
I was thinking of
very
something else.
quickly, has no recollection. You ask her the next
Okay.
day.
Sorry.
You remember any episode or anything in particular, the patient is most likely to be amnestic. You can have episodes of a sleep apnea. In this particular example, from a University of Michigan, Dr. Hoban, I believe. This is a patient who has this abnormal flapping type movements as related to untreated sleep apnea. As a manifestation of the confusional arousal sexsomnias. I want you all to remember this are really key and important conditions with forensic implications. Always ask your patients about sexsomnias by simply including this as part of the sleep questionnaire. Patients don't often volunteer this information because they're often embarrassed by the behavior that tend to be fairly aggressive and inappropriate sexual behavior towards a bed partner, towards individuals who are close by. They in close proximity to the patient, sleeping, happens on planes, and unfortunately has important forensic implications. Let's move to somnambulism. Here there is displacement, abnormal displacement related to an arousal. The patient appears to be confused, disoriented, as you can see in this particular example. There is some degree of ambulation with return to bed and amnesia and no recollection the next day. Now, if you have eating as part of if the patient goes down and starts eating, that's sleep-related eating. If that's also associated with amnestic nocturnal eating, and the food items here are usually not ones that would be common for the patient, and again has some interesting implications related to weight gain and potential injury, but also the fact that this may be found, the sleep-related eating may be found in patients who have restless leg syndrome and are given a hypnotic only to manifest with amnestic sleep walking. Very likely to occur in children. Here you can see some of the comorbidities in adults, particularly hypnotics. And it's often associated and comorbid with Willis-Ekbom disease, restless leg syndrome. Folks are given treatment with a hypnotic with sedating properties that are often masking the RLS type symptoms where the patient has amnestic eating. As you can see, here is another patient, University of Minnesota, Mike Howell's group. You can see that, but there is a bruxism type artifact as the patient is eating their favorite snacks and has no recollection for that. Let's move to sleep terrors, probably the most dramatic of the parasomnias, where they are characterized by tremendous automatic discharge, pathetic hyperactivity.
No, sit down, you're all right. No, don't fall on him, Fred. Don't fall on him. Hey. No, you're all right.
And you know, what's interesting here is they don't really respond to any efforts to, when the parents come to the child's rescue, the child becomes even more aggressive. So the best thing is to let this episode go through with just a anticipation that the patient will recover at the end, but making sure that they're safe and they're not at increased likelihood for injury. You can see the patient here is fairly, looks like in a state of terror. And really the differentiation from nightmares is that nightmares are usually less likely to be severe, less likely to be associated with sympathetic hyperactivation. Sleep terrors are folks are going to be confused, disoriented, the episodes are going to be intense, and dreaming is very common in association of a bad image hallucination with nightmares, and less likely to be the case with sleep terrors. Now, in terms of differential, I really provided you with some specific examples of semiology as I went through the talk, but remember, this is how it's going to be manifesting. The confusion, the motor activity of walking, the appearance of terror or dream enactment, the timing, early versus late, early being non-REM parasomnias, late during the night are REM parasomnias, and seizures occurring really in between, primarily during non-REM, and knowing the EEG hallmark of a augmented EMG tone, phasic bruxism type movement where patients may have episodes of rhythmic movement with a periodic discharge involving the EEG, or an abrupt arousal with the patient appearing to have an admixture of non-REM and wakefulness, and maybe a more ictal spikes and slow wave activity during non-REM sleep in the setting of nocturnal seizures. And what I want to just remind everyone, the differentiation of nocturnal sleep-related epilepsy, highly stereotyped, complexity is uncommon. It's more common with the parasomnias, but the nocturnal frontal lobe seizures usually present with more frequent episodes per night in the first 1/3 of the night. Now, in terms of evaluation, as I mentioned to you, polysomnography is really a requirement only of a RBD, REM sleep behavior disorder. Everything else, say sleep logs and questionnaires and nighttime sleep duration activity, sometimes if you presume the patient may have a circadian rhythm abnormalities and short sleep duration, may be helpful in the assessment of parasomnias, but polysomnography by and large is required for RBD diagnosis. And if you suspect that the patient may have a specific trigger related to untreated sleep apnea and in relationship to being able to define a definition by semiology based on whether they have other parasomnia-like events that need to be addressed. I'm going to go through very quickly just some of the safety intervention as universal treatment. Everyone will benefit from a safety intervention. Anticipatory awakenings are usually to anticipate when the patient is having their episode and to awaken the patient ahead of time. This is done usually by the parents for some of the pediatric parasomnias, and they hope to provide the patient with some relaxation or tell him a story with the hope of extinguishing the episodes. Pharmacotherapy, I'm going to let you read through this really on your own, but by and large, the benzodiazepine type drugs are quite helpful for all parasomnias. And when they're frequent, and certainly when they lead to aggressive behavior or injury, that's the time in which you may start picking and choosing this particular agents. And for the REM parasomnias in the setting of RBD, certainly clonazepam and melatonin are quite helpful. Remember, in making the differential, knowing about the age of the patient, semiology, timing, motor activity and its intensity, and really in being particularly mindful that older adults who present with dream enactment where the motor activity is aggressive really leads to almost always a concern of RBD, whereas nocturnal seizures, there may be underlying organic CNS lesion. And I'm going to just finish here and let you, I will have the slides and certainly the tables for everyone to look at your own leisure, but really to let you know that part of making the differential and making and ascertaining what kind of intervention you may be thinking of really depends on making the appropriate diagnosis. A lot of our patients who come in to see us for parasomnias are often ill-advised, or someone did not really go into as much detail to get the clinical history correctly, and that's why probably they're getting the incorrect diagnosis, and that's why often you will see that the treatment plan has not succeeded. And with that, I'm going to end. And at this point, I think we have a few minutes to take some questions, and I'm going to go back and see if we have any questions. So I'll turn it over to the moderators, and I hope to be able to answer any questions that folks may have. This concludes the formal presentation. Thank you so much for your attention, and I'm now able to answer questions as part of the discussion. Thank you so much. So let's take a look here. What I'm going to do is go through some of the, here we have a question. The question here is, does REM without atonia by itself or subclinical RBD also leads to neurodegenerative conditions? This is a really, really good question. More and more data shows that folks who may have REM without atonia, really, those are the individuals who present with abnormalities of a REM sleep. Remember, these are the folks who present with a just simple REM without atonia, just the signature PSG phenomenon. And here's the example. Here's just the PSG, but they haven't had yet a dream enactment behavior. And data shows that yes, if the patient has REM without atonia by itself, without dream enactment, this can still be a sign for neurodegeneration, which is why I think if you ever look at the muscle tone during REM sleep, if it's elevated, that by itself can give you and can needs to be documented, and it needs to be discussed with the patient, but also to be more mindful to be able to ascertain, does the patient really denies dream enactment? Is there any way that perhaps there could be an observer, or if the patient leaves alone and there is no history of dream enactment behavior, that you could include maybe a camera during the night and maybe a recorder to ascertain if you really truly do not have a dream enactment. But the answer to the first question about REM without atonia by itself or subclinical RBD leading to neurodegeneration conditions, and the answer is yes. Next question is, what percentage of total REM epochs needs to show excessive EMG twitches in a patient PSG for the diagnosis of REM without atonia? So the total REM epochs, this is not well defined. And I hope that the next classification of the International Classification of Sleep Disorders will include a little bit more definition. Do you need one REM epoch, or do you need two, or do you need to demonstrate multiple number? And for by and large, if you have one 30-second epoch during the entire recording demonstrating REM without atonia, that's sufficient for polysomnographic confirmation. But certainly we know a lot of people who do not have REM sleep, or have very little REM sleep and very little REM without atonia. So we do need to have a little bit more specificity, and that will be coming up mainly through work by many of our colleagues at Mayo Clinic and University of Minnesota and other key RBD study sites. Next question is, does melatonin or clonazepam prevent or slow progression to neurodegeneration in RBD patients? Another key question. All of you are asking really wonderful questions, and the answer right now is probably not. We know that melatonin is simply effective in ameliorating the dream enactment, so is clonazepam, but they do not prevent, and they do not slow the progression for the neurodegenerative disease in RBD. The only thing that we know of so far that you can advise patients is exercise. We know that exercise does have some neuroprotective effects in Alzheimer's dementia, probably also in Parkinson's. It doesn't prevent completely, and it doesn't slow in the majority of patients, doesn't have any specific number that you can give patients that this will cut the risk by 50%, but we know that those individuals who exercise regularly, daily for about 45 minutes are probably less likely and perhaps have a lower rate of transformation, but I can't tell you by how much. Next question is melatonin given at night of sleep or 2 hours before? So the question here is, when you use melatonin in the setting of REM sleep behavior disorder, do you give it right before the patient goes to bed, or do you give it as you would in some of the delayed sleep phase patients a little bit before? And the answer is right before bedtime. I usually give it about 15-20 minutes before bedtime. And I generally recommend that patients start at, let's say, 5 milligrams of melatonin time release for the first 1 or 2 weeks, and then have an ability to judge, is it really are the episodes less frequent, or the less severe, and being able to go up to 10 milligram time release if the episodes persist, all the way up to 15 milligrams if the episodes persist. But you have to give it right before bedtime, and there is no, really, the idea of giving it early is really for folks with delayed sleep phase in effort to advance them to an earlier time, and that's the only time you would give melatonin a little bit earlier than the intended bedtime. I don't see any other questions. Oh, here's one more. Some people are sensitive to melatonin and some are not. What is the reason for that? You know, sensitivity, I suspect the fellow is asking whether they are more likely to experience sedation or experience adverse, say, sleepiness the next day. And I'll tell you, by and large, probably in the last few years, we've seen maybe 1 or 2 patients who experience some difficulties with melatonin, perhaps more sedation and more vivid nightmare type episodes. And I would probably ask, is the patient really experiencing any sleep deprivation? Do they have untreated sleep apnea? It's uncommon for folks to be very sensitive to melatonin at the doses that we use for RBD. So I don't have a good reason except to say you have to look at and demonstrate the patient is not sleep deprived, probably not using some other medications or other drugs, or if they're using clonazepam and melatonin, you might want to titrate off the clonazepam to a bit lower dose and maybe try a lower melatonin dose. But this is a highly, or I shouldn't even say highly, it's probably unlikely. And if it does happen, then you may want to switch to a lower dose and perhaps use a combination of clonazepam and melatonin, at both of them at a lower dose to hopefully get rid of that side effect. Yeah, I'm going to take one more. So there is a, if a patient if no REM sleep without atonia, but witness REM-like episodes, what diagnosis do we give them? So if the patient has no REM without atonia, but they do have witness dream enactment, you give them a diagnosis of dream enactment behavior, or the other term for it is clinically probable RBD, and I would treat them as the same. I would probably advise patients of the same risk, but they will keep probably getting another sleep study later on. Perhaps you didn't have a good ability to capture the episodes because the patient didn't go through and have appropriate REM period. Someone is asking for a copy of the slides. I would absolutely make this available later on through the AASM, so you'll see the tables. Can you please repeat the affected areas in the brain which cause secondary RBD? I've demonstrated the perilocus ceruleus, the area in the brainstem called the rostral pons. And finally, does clonazepam suppress behaviors, or is it also suppressing the finding of REM without atonia? So clonazepam does improve the behaviors, but it does not restore muscle activity on the PSG. The only drug that does it, to my knowledge, is melatonin. So with that, we're right at 9:15. It's my time, 9:15. I know we need to be done at 15 minutes after the hour. So I really want to thank everyone. Thanks for all the excellent questions and the opportunity to share some of my knowledge on parasomnias. Thank you so much, everyone.